So moving on to the pediatric spine X-rays and differentiating the abnormal from the normal. First, we need to understand that the normal looking spine X-rays in the pediatric age group by themselves are quite different from what is seen in the adult population. The bones are relatively smaller, they are thin, the landmarks are not visualized well. As mentioned by the previous speakers, the cartilaginous end plates are quite thick. The disc and the ligamentous complex are quite stronger as compared to the bone. So all these things have to be considered before we actually go on and make a diagnosis on the X-ray. Having said that, certain basic things remain the same once the child is past the walking age, that is the normal spine alignment. So in the standard AP X-ray, you'll see that the spine is straight, symmetrical, and the head is nicely balanced over the pelvis. And in the sagittal view, there is evidence of cervical and lumbar lordosis and thoracic and sacral kyphosis. Any deviation from this can be very easily picked up on a cursory examination of the X-rays. Like in this case, the most common ones which are found is the lateral deviation of the spine or the scoliotic curves, and if there is presence of kyphosis, that is loss of thoracic normal kyphosis with exaggeration. Also certain abnormal ones, like in this particular case, you can see that there's a significant loss of thoracic kyphosis. Not only that, there's hyperlordosis of the spine, and these are the conditions which are syndromic in nature and almost diagnostic on the X-ray. Here you can see there's no evidence of any kyphotic zone in the spine, hyperlordosis all throughout, and this is a syndromic patient. Moving on to the local areas, the cervical spine, the normal examination, normal points should be noted like bony landmarks, the facet joints, the spinous process, the vertebral bodies, and also it makes sense to make a mental note of these three lines, the anterior, middle, and the posterior spinous process line. Any deviation from this can give an idea of abnormality. Also, certain soft tissue landmarks have to be taken note of. For example, the height of the disc spaces, the retropharyngeal space proximally, which is around 5 to 7 millimeters, the prevertebral space in the subaxial spine, which is around 14 millimeters, up to 14 millimeters in the children. And finally, on the AP X-ray, a note should be made of the uncovertebral joint, which shows the alignment, and the presence or absence of a tilt, which is usually found in cases of torticollis, which is very common in pediatric age group. This is a classical example of how we can pick up if we have normal anatomical landmarks in our head. The X-ray in the middle shows that there is loss of disc space between C3 and C4, indicative of intradiscal destructive pathology, which may possibly COX. We have to prove it by biopsy diagnosis. Also, the X-ray on the extreme left, here you can, the most obvious thing which is obvious is the presence of an atlantoaxial dislocation. However, if you see all the bodies over there, they look very fuzzy, the margins look very fuzzy, and that should give you a suspicion that this is not only atlantoaxial dislocation, this is normal, this is a deviation from the normal, and this patient had extensive COX, which turned out to be a total drug resistance, which was not salvageable. So these are the diagnoses which you can easily pick up. Certain radiological examinations like a swimmer's view, which is essential, and an open mouth view, which are essential for you to have a diagnosis or suspect a diagnosis in a particular area. In the supraxial spine, you need to be aware of the normal anatomical landmarks, that is the C1, C2 anatomy. Follow the C1 ring, the C2 body, and the posterior elements of the C1, C2. The atlantodense interval is normally up to 5 millimeters in children. You need to make a mental note of the tip of the dens and the skull base. Here are some of the abnormalities in which all these parameters are disturbed. The C1, C2 anatomy is disturbed. There's an increase in the gap between the anti-arc of C1 and the odontoid tip, increase in the ADI distance. The tip of the dens is not in its normal position, and also in the lower X-ray you will find that there is fusion of C2, C3. Again, these are indicative of syndromic cases, and almost all these cases are diagnostic on an X-ray if you know the normal anatomical patterns. Along with this, there are certain complex syndromic cases, like in this case where there are abnormalities in the supra and the subaxial cervical spine, and these again go in favor of syndromic cases. So all these things can be diagnosed on the radiological examination if you know the normal looking X-ray. Certain X-rays like open mouth view, which is relatively difficult in a pediatric age group, but you can still try, which delineates the C1, C2 anatomy better. The space between the C1 lateral masses and the C2 lateral masses is better delineated on the open mouth view. Also the relationship of the dens, the tip of the dens with the lateral masses, and all these things are disturbed in a rotary subluxation in a Bachu where the torticollis is very common, and a C1, C2 dysplasia or rotary subluxation can be very easily missed if you just consider that the sternocleidomastoid could be a cause of the torticollis. Moving on to the dorsal spine, again the basic pattern is the same. You need to make a note of the alignment, the vertebral bodies and the spinous processes, the anterior column which indicates the disc space and the bodies, the middle column, the pedicles and the soft tissue shadows. One important thing is in the pediatric age group is that although we feel that the pedicles are small, if you compare the diameter of the pedicles to the vertebral bodies, they are quite big. Okay, so there's a reversal of ratio between the pedicle and the vertebral bodies, which works to our advantage whenever we are planning a instrumentation. Disturbance in these patterns again can be very easily picked up on radiological examination. For in this case, it's a proximal junction kyphosis. The reason could be a tuberculous involvement, or it could be abnormality in the normal AP X-ray where there's crowding of the ribs and there is abnormality in the pedicles if you see, and again these are classical findings in case of a dorsal hemivertebra. Pyogenic infection, classical diagnosis, presence of intact disc spaces with destruction of multiple vertebral bodies is almost diagnostic, and again traumatic conditions which are very well visualized. Lastly, the lumbar spine, again systemic exam evaluation is important. You need to know the normal pattern, that is the lumbar lordosis. You need to make a note of the end plate, especially in this age group. In the late pediatric or the early adolescent group, pars fractures are very common, and that is something which can be missed. The pattern in this particular age is extremely different from what we've seen in adult patients. There's an elongation pars, there are sacral dysplasias, and this makes the management very, very difficult, because as opposed to the adult age group, in the pediatric age group, since it's a developmental anomaly, there are associated neural anomalies as well in addition to the bony anomalies. So again, infection is almost diagnostic, which can be confused with a hemivertebra, and deformities, as I said, are diagnostic like a hemivertebra or a scoliotic deformity. Finally, most important in pediatric age group, you should make a note of the soft tissue shadows, because they tell a story more often than not. The pattern of destruction can be picked up quite early in this age, because by the time the radiological changes do manifest themselves, it might be late. So you have the classical thoracic abscess, the bird's nest appearance in the thoracic spine, or the prevertebral shadows, or the abscess in the cervical spine, and you should make a note of the lumbar, the psoas shadows in the lumbar spine, because psoas abscesses are quite common in these kids. So that's it. I thank Swapnil, and it's been a learning experience having an innocent spine surgeon over here in presence of pediatric orthopedic surgeons. Thank you.